Good morning. I'm Jennifer Stacy, and I will be your host for the next hour. Thank you for joining me today. I'll start with some quick housekeeping for today's event. Your cameras are turned off and your microphones are muted, but that doesn't mean that you can't join the conversation. I encourage you to participate by submitting your questions and sharing your thoughts via the Q&A function. We'll work to answer your questions throughout the discussion, as well as save time for the Q&A at the end. And now to introduce our experts. Joining me today is Alfred Lyman, our Executive Director for Regional Pharmacy Services. Junior leads inpatient, outpatient, and clinical pharmacy services for Kaiser Permanente Northwest and is a collaborative member of the Kaiser Permanente National Pharmacy Leadership Team. In addition, he's a clinical assistant professor in the Department of Clinical Pharmacy for the University of Colorado Skaggs School of Pharmacy and Pharmaceutical Services and is an affiliate faculty member at Oregon State University College of Pharmacy. Junior also serves as the immediate past president of the Oregon Society of Health System Pharmacists. Outside of work, if you can believe he has any time, Junior enjoys traveling the world and enjoying great food wherever he goes. Sunshine Summers is the Director of Clinical Pharmacy Services at Kaiser Permanente Northwest, where she leads various teams who provide ambulatory pharmaceutical care to our members. Sunshine earned a Bachelor of Pharmacy from Drake University and her master's degree in Pharmaceutical Outcomes Research at Policy from the University of Washington. At Group Health Cooperative, which is now KP Washington, she implemented Epic Care and developed an interest and expertise in medication safety and clinical informatics. She joined Kaiser Permanente Northwest in an informatics and medication safety role for 10 years before moving to the Drug Use Management Team, which we call DRUM, as a pharmacy analyst. In 2017, she moved into a management role leading DRUM and our clinical pharmacy specialist teams. In her free time, Sunshine enjoys running, gardening, jigsaw puzzles, watching basketball, and having board game nights with her wife and daughter. And now to the program. At Kaiser Permanente, we exist to provide high-quality, affordable healthcare services and to improve the health of our members and the communities we serve. To achieve this, especially in a time of extraordinary cost pressures on our community's health systems, maximizing efficiency and effectiveness of our pharmacy program and the quality of care for our members is paramount. Today, we'll talk about some key elements of our pharmacy strategy. Leveraging our size to personalize care, driving affordability through evidence-based prescribing patterns, supporting members in taking their prescribed medications appropriately, and controlling drug misuse, particularly opioids. Now I'll turn it over to Junior, but please do remember to use the Q&A for your thoughts and questions. Junior, Sunshine, welcome.
Thanks, Jennifer. I'm really excited to be here with all of you today, and thanks for the wonderful introduction. I hope by the end of this presentation, you will all be as passionate as I am about pharmacy and maybe even have your amateur pharmacy degrees here by the time we're all finished. But I know this is probably a topic near and dear to all of you as well. It's one that we get a fair amount of questions about as both the insurer and being on the healthcare delivery side. But I don't think it's any surprise in just starting out that, prescription drugs are certainly increasing in costs as we move forward. There's a lot of drug development going on, especially in the specialty drug arenas. And we're seeing just phenomenal price increases as these drugs come to market. And there are several reasons for that. Many of them are listed on your slide. I won't read all of those in detail. But I think this is where our integrated model at Kaiser Permanente really does help us because we're not only acutely aware of what's happening in the market around our prescription medication costs, but then what we can do to try and help control those costs. Another piece of this is just the aging population. So as we have more and more of the baby boomer population moving into aging, that's also contributing to increased drug costs that we are seeing. Not to mention just more and more, we're seeing more combinations of drugs used to treat chronic conditions. So for example, when a patient, may get a new diagnosis of, say, for example, diabetes or heart disease, we're seeing, many medications that need to be used to not only treat the condition, but also for preventative measures as well, which is something KP is very big on. So that's also contributing to those rising drug costs. Lastly, I would just also mention, and I'd be remiss to say that I do think that direct-to-consumer advertising also has some impact here. I think just watching the national news last night, I think I saw no less than 6 or 8 ads for medications that are now on the market. And so that's certainly making an impact and has been making an impact on what we're seeing in drug costs. Next slide, please. So I mentioned a little bit about our integrated model at Kaiser Permanente, and certainly being both the insurer and the healthcare delivery system, but also in how we're integrated specifically within our pharmacy services. And so really thinking about our pharmacy services, we really do have a great ability, and we take it very seriously and take this challenge head on, which is to really look at how we can help control drug costs from all the way from purchasing and contracting to warehousing our own drugs, all the way through to delivering prescriptions to our members. And so that integration really does help us to be able to control. And we're one of the largest purchasers of drugs in the country. And so that really does help us to look at how we can procure great contracts on medications to help drive down costs. And then certainly our integrated model and how we partner with our physicians, other clinicians, nurses, our formulary managers, even what we do on research to make sure that we deliver that superior, high quality, safe care to our members, but also making sure that it's affordable. And being, not for profit, that is something also in pharmacy that we take very near and dear, which is, we're spending our members' money. So we want to make sure that we're good stewards of our members' money, and especially when it comes to medication costs, because we know it is a big driver of costs for our employers, our groups, and our members as well. Next slide, please. So again, a little bit more about our integrated model and how we use that to help deliver high quality care and better outcomes. And so really it does start with our evidence-based medicine. We partner in pharmacy, our pharmacists, our clinical pharmacists, partner very closely with our physicians, and it all starts with, when we're evaluating medications to add to our formulary. And so in looking at that, we really do look at 3 things. And I think the last one that I'll mention here is where it is a differentiator for us in KP, which is certainly any drug that we add to our formulary, first and foremost, as the #1 priority, needs to be safe. The second thing is it needs to be efficacious, right? It needs to be effective for whatever condition that we're adding it to the formulary for, to make sure that it is a high quality treatment that we agree that there's good evidence for. So once that safety and quality is met, and as with many things in pharmacy, there's more than one drug to treat the same condition, and many of those drugs can be equally safe and efficacious. And the third is where we really differentiate ourselves, and that is we really take into account the affordability. So certainly if we have 2 drugs that are equally safe and efficacious, but we can obtain one at a lower cost, we're going to choose the one where we can go with a lower cost to still provide that safe and efficacious care at a lower cost to our members. And that's really one of the things that helps drive our relationship even with drug manufacturers as we look at purchasing our drug contracts, is we're really have the ability to move market share to whatever agents we deem as our preferred agents to treat, say, a certain condition like high blood pressure or diabetes or heart disease. So that really does help us to drive that. And our formulary is all led by our physicians with our pharmacists closely partnering on our committees and making sure that we have that. The collaboration really is important here with what we do. So our pharmacists are integral healthcare team members that work in many cases right alongside our physicians. So in Kaiser Permanente here in the Northwest, we do have a large area of clinical pharmacy services which Sunshine helps lead. And that is a lot of our pharmacists work in, say, for example, different specialty areas. So just a couple of examples, we have pharmacists who specialize in hepatitis C. We have pharmacists who specialize in infectious disease and antibiotic stewardship. We have teams that focus on opioids and reducing risk with opioid prescriptions. And then even some of our specialty areas like dermatology, rheumatology, gastroenterology, where we have very high cost drugs. We have pharmacists that work alongside those physicians to really help look at opportunities that we have to make sure that we're using the right medication, the right dose for the right patient at the right time. And that's really a core fundamental kind of philosophy that we have, is we want to make sure that we're using our drugs, to the fullest potential and using them where appropriate, and making sure that we're working alongside our physicians in that process. And that really does help make a difference for how we can help control and curb some of the rising drug costs. And I think especially in some of these specialty areas, it is really important to note that we're not going to be able to reduce costs in many of these areas. It is really about controlling the rate of rise. We've definitely seen, large increases in some of those specialty areas, and that is likely going to continue. And so one of our key goals there is just to continue to stem that rate of rise where we can, and then certainly look at opportunities where we have to reduce as well, while still maintaining that high quality care that we're committed to. One last thing I just want to quickly mention about this particular slide. I mentioned a little bit about how our physicians really drive our formulary, pharmacists provide that support. One of the other things that's, I think, very different with KP is we don't have a lot of external influence from pharmaceutical manufacturers or the representatives. So in KP Northwest, we actually don't allow pharmacy reps on our property at all. We do all of the drug detailing. We take that on in pharmacy. So if there are questions that our clinicians have around a particular medication, developing our drug monographs to present to our formulary committee, all of that is done in partnership with our physicians and our pharmacists. And so we provide that information to our medical group rather than having the influence from pharma. So think of it as kind of trying to eliminate that direct to prescriber advertising, similar to the way we see direct to consumer advertising. We really want to make sure that we're providing unbiased information about our medications and as we make those selections for our drug formulary across not only the Northwest, but the enterprise.
Junior, thank you. We have a question that's coming from the audience that I think is really appropriate. You talked about the number one goal being safety for our medications. And the question is about FDA, and isn't that the goal of the FDA to make sure drugs are safe and effective? Is there a difference between that and KP decision making, or how do they work together when you're determining what goes onto the formulary?
Yeah, thanks, Stacy. It's a great question. I can answer, I think, a portion of that, but to be honest and fully transparent, I'm not 100% up on the full FDA process that they go through to determine. I know there's an application that's submitted by the manufacturers. The FDA and their panel of experts then review those drugs to see if they are safe and efficacious. What they don't take into account is the cost of the medication. However, I would say that, again, just because a drug is FDA approved, certainly we learn more about drugs as they come on the market. So that's something we call post-marketing surveillance, where we're constantly looking at drugs once they've been approved and they've been on the market. We have more experience with them. Sometimes things can be uncovered that we didn't know when the drug was first FDA approved. So side effect profiles may change as you get more real world experience. So that is something we take into account, but certainly not every drug that is FDA approved is going to be on our formulary. And again, much of that boils down to there may be, say, for example, 10 different medications that can be used to treat the same condition. And that's where we partner with our physicians closely to take a look and see what's on our formulary and how we want to best position those medications for use by our members.
Thank you.
Sure. Next slide, please. So looking at our connected system, and how we stay integrated, really this does, again, help us control those costs without impacting quality in an adverse way. And I mentioned a little bit about our, supply chain and our contracting, and I'd like to go into just a little bit more detail about that, because I think it's a little bit different, again, at KP than it may be with other insurers or other kind of players in the market. And that is really how we approach contracting. So whenever we send out, medications to bid or a class of medications to bid to various manufacturers, we really are looking to how we can obtain a long-term contract that's going to secure the best possible price that we can get, and then pass those savings on to our members. And so one of the key differences here with KP is we really look for that upfront discount in the medication price that we can get from the manufacturer, rather than rebates on the back end. And oftentimes what you see outside of KP is those rebates, they're not regulated. So a lot of those rebates may go back to the pharmacy benefit manager or to the health plan itself. It doesn't get reinvested back into our members or, again, in those upfront costs. And so we really try to steer away from contracts that have a lot of rebates on the back end, or certain utilization. We really try to key in on that upfront discount. And one of the things that I think really helps us in this space is just our reputation at KP, and that when we have contracted for a medication, and especially if it's a preferred agent for us, the manufacturer knows that we're going to be able to drive utilization to that particular product to make sure that we're maximizing the contract, and making sure the manufacturer knows what kind of supply we'll need, and making sure that we don't have as many issues with some of the drug shortages, et cetera. Now, that's not to say we're not still impacted by drug shortages. Those things still happen. And that's something we've really seen compounded during the pandemic, which oftentimes during some of those shortages, we actually see increases in our drug prices because we're having to use non-preferred agents or switch to a different alternative because our preferred agent is in short supply. The generic drugs, is something that we very much move to whenever possible, a generic medication. They are equally safe and efficacious compared to the brand counterpart. The FDA does help establish that and that interchangeability of how we can use generic medications once a brand name medication becomes available. And we really steer our utilization through our integration with our medical record, with our providers, our contracting, our systems, all the way from basically beginning to end, that whenever a generic drug comes on the market, we're very quickly able to move from the brand or the innovator product over to the generic medication. And by doing that, we've been able to achieve about 94% of our medications that we use are in the generic medication space, compared to around 90% as to what we see in the marketplace outside of KP. And that, it's surprising, but just due to the high volume and the number of members that we serve, a 1% change in our generic utilization can equate to millions in savings. And so it really is a big deal to make sure that when a generic medication is available, that we're able to switch to that very quickly. Just lastly, on the strategic purchasing part of this, I mentioned a little bit about how we go out to bid for various medications, try to secure that lowest price that we can get. The other thing that we really look at, and we have internally within KP our own warehouses. So what we'll often try to do is warehouse products. Like if we know, for example, that a price increase is coming from a manufacturer and we have the opportunity to buy up product in advance. In some cases, depending on the expiration dates of the medications, in some cases, we may even buy up to a year's worth of medication or even longer and warehouse that product and then disperse it out to our distribution centers and ultimately our pharmacies where our members get their medications in order to hedge some of those price increases. The other piece that warehousing component really does offer is oftentimes it can help us in situations like, great example is during the pandemic when we're able to know about shortages that are coming to try and at least get some safety stock of medications warehoused and or alternatives so that we don't, again, run out of medications. Again, it's sometimes we still can't prevent it, just depending on how severe the shortage is. But that warehousing component really does help us to hedge some price increases and even price increases that we may see from having to use an alternative product during a drug shortage. Next slide, please. One of the things that we have in Kaiser Permanente also is our own specialty pharmacy. And so in Kaiser Permanente in the Northwest, we actually partner with a specialty pharmacy that's based out of our Northern California market. And they provide many of our medications that are deemed specialty pharmacy medications. One of the questions that I often get is, well, what is a specialty medication? And there's no agreed upon true definition of what a specialty medication is. But oftentimes these are very expensive drugs that cost, say, for example, greater than $600 or $800 for a 30-day supply. And then oftentimes they have very specific requirements that are attached to them. So for example, a risk evaluation and mitigation strategy, or we call it REMS in the pharmacy world, where the FDA and other governing bodies have put in very strict criteria because there may be a potential risk of significant adverse effects or side effects that we need to control for. Oftentimes, they may have limited distribution. So for example, a manufacturer only contracts with a few pharmacies to distribute their medication. Those types of medications are often what we deem as specialty meds. And those are the ones where we use our integrated specialty pharmacy model. Again, by bringing those drugs directly in from the manufacturer, we don't go through a third party in many cases to procure those medications. So it can help us realize some savings there. In addition, our specialty pharmacy really does help with, they have, obviously pharmacists, technicians, and others who really help look at the medications they're dispensing and can really help with adherence and looking at lab monitoring parameters or other things to make sure that patients are up to date on what those monitoring parameters are, making sure that they're taking those medications as prescribed. Because again, it's really important here, same concept I mentioned earlier, right dose, right med, right patient, right time. And if we're seeing something, for example, a patient who is not as adherent to the medication as it's being prescribed, is to really dig in and find out what those barriers are. Is it a cost barrier? Is the patient experiencing side effects? Are they just forgetting to take it? Really trying to dig into those to understand so that we can, again, maximize the use of those medications to provide the high quality care that we're looking for in that specialty pharmacy space. And so that case management really does account for, a big portion of the value that we get from having our internal specialty pharmacy there. I think one of the most powerful things on this slide is just really the bottom portion. And it's something that we even see here in Kaiser Permanente in the Northwest, where, currently in pharmacy, over 50% of the dollars that I spend on medications are driven by less than 1% of the volume. And, at KP Northwest, we dispense over 6 million medications per year to our members. And so just putting that in perspective, a few thousand drugs in many cases are driving more than half of our costs. As a pharmacist, I didn't think I'd ever say this or ever see it, but we've just hit our first $3.5 million drug for one dose, one treatment for a certain condition, a specialty medication for hemophilia that we see. So we're really seeing a lot of this is where a lot of the drug development is going, is into this specialty drug class. And so this is something that we really pay a lot of attention to and are really keen to looking at, again, what is the evidence behind these medications? How do we partner closely with our clinicians? And even what can we do to help maximize, when these drugs are appropriate, maximize the quality care that we want to deliver at the lowest cost. And so one of the things that we've put together in KP as an example is our emerging therapeutics group. And so whenever we have these very niche medications for specific conditions, is really making sure that we're, again, using it in the right patient at the right time And so oftentimes we'll have a group of clinicians reviewing that type of data to make sure that, yes, this is the most appropriate drug to use for this particular patient. And so just knowing that this is where our spend is going, this is, again, an area where we're probably not going to be able to decrease it. It's more about controlling that rate of rise and how can we kind of bend the trend to make sure that we're not seeing those very big price increases where we can try to avoid that. Next slide, please. Biosimilars is something that we really have endorsed heavily within KP. And again, I think this is something that really sets us apart. Biosimilars are not a generic medication. They're often referred to as generic, but they're not an exact replica or copy of a brand medication. However, they are very effective, equally as safe, and work the same way as the innovator products do. And they really do offer significant savings whenever they're adopted. And what we see in the biosimilar space, and especially at KP, is that we're often able to reduce costs by 30% or more whenever we switch to a biosimilar. And what we've been able to do in KP is really drive our utilization up on those whenever one comes on the market, such that we're often seeing 95+% of patients move over to the biosimilar medication and off of the innovator product. And especially when you compare that to what we see in the marketplace, the market share of biosimilar utilization is much, much lower. And oftentimes that's really driven by many different factors. It can be driven by pharmacy benefit managers and what, again, if they've negotiated rebate contracts with the innovator product, there can be lots of various reasons why biosimilars aren't necessarily adopted. And just based on our own experience and even data that we've published out there, we're really seeing, great outcomes still with biosimilar products. And it's really made a difference for us and what we've been able to achieve in some of our drug cost savings. I think, I just want a special shout out here to our clinical pharmacy teams as well when it comes to biosimilars, because I will tell you this is a huge undertaking whenever we learn about a biosimilar product coming to market. So one of the first things that we do, as I mentioned before, is on that contracting side, right? Really trying to figure out, are we going to be able to get a good price on the biosimilar product? Does it make sense for us to consider this for our members? And then the next thing we're doing is looking at the evidence, looking to see what's been published out there, what data we have to show that the biosimilar is safe and efficacious. And then the very next step is really partnering with our physicians and our clinicians who prescribe these medications to talk through and make sure that we're aligned. We really look for consensus, not only across KP Northwest, but across the enterprise, across all of our different markets across KP, to make sure that we're aligned and that we can move to the biosimilar. And in particular, oftentimes in doing that and carefully reviewing the evidence behind these medications, is we might identify a population of patients where, for example, we decide it's best not to switch to the biosimilar product until we get more experience with the medication, get more data, and get some more, again, of what I call that real world experience once the drug has been released on the market, versus just the study data that might come from the manufacturer that got the drug approved in the first place. And so that is also something that we take very seriously when looking at those. And our clinical pharmacy teams, once we've made that decision, really help in how we coordinate moving from the brand product or the innovator product over to the biosimilar. And so a lot of these drugs, for example, in the oncology space, our oncology teams, our oncology clinical pharmacists will be working closely with patients to make sure that when we make the transition, the patient understands if there's any nuances with the biosimilar, as far as, for example, if it's an injectable medication, making sure the patient understands the nuances with the injector, making sure the patient knows how to use it, making sure they know the appropriate dose, who to call, where to call, which oftentimes will be the pharmacist or the physician if they're having any problems, so that we can troubleshoot and try to make sure that we're available as the patient goes through the transition over to the biosimilar. And we have many teams that are involved in that on the clinical side, as well as even in our outpatient pharmacies, and making sure that our patients stay safe, stay informed, and that they know where to go if they experience any issues or problems with those. Next slide, please. So again, I mentioned, a couple of drugs in the oncology space, and there's, 3 examples that are listed here. And just in a couple of months, we were able to quickly move to over 90% utilization of 3 different medications that we use a lot in cancer care, but some of these drugs can also be used for other indications where we can also see some of those benefits. And again, just looking at, it's significant dollars, $140 million in our first year of cost savings with these 3 biosimilars alone. And there's more coming on the horizon. And one that I want to talk about just briefly to give you a real world example is Humira. So Humira has been one of the top selling drugs in the United States for years as far as generating revenue. It's a very high cost drug. It's used in many patients with rheumatoid arthritis and other conditions. And recently, a biosimilar and more biosimilars are coming on the market. And just within the last month, we were able to procure a product called Amjevita, which has been available in Europe for quite some time. Europe tends to have better adoption quicker of some of the biosimilars than even in the United States. So there's, some real world data out there that we have from patients who have taken these medications in Europe. And just within the past month, we have started moving from Humira over to Amjevita. And we've seen a very positive uptake and great feedback even from members thus far in switching to the new medication. It's been very seamless. And at this point in time, just across the enterprise with how widely Humira is used, we're achieving a cost savings of $1 million per day across our enterprise by moving to this new biosimilar product. So it's just an example, and there's a lot of coordination and effort that goes in behind the scenes, as I mentioned. We developed some training and education for our outpatient pharmacists so they could appropriately counsel members whenever we sell a prescription, either from our outpatient pharmacy or prescriptions mailed. So that's a huge benefit that we have, is making sure, again, our patients are well versed on that new medication that they're getting. And then our clinical teams to help, as I mentioned, with those conversions and troubleshooting any issues that come up. But the Humira to Amjevita has been a very early success story so far in 2023, and just excited about where we're headed with that particular medication. Next slide, please. So one of the other topics that we wanted to talk just briefly about is our medication adherence. Again, we can prescribe all the medications in the world. It doesn't matter. They're not effective if patients don't take them. And so really there's a couple of different approaches that we have to medication adherence. First is one that we call primary adherence or primary non-adherence, where maybe a medication is prescribed that a patient never picks it up. And for whatever reasons decides that they're not going to take that medication. We have ways of identifying that through our integrated system and our data teams, so that our clinical pharmacy teams working alongside the providers can outreach the patient to find out why they have chosen not to take a particular medication, to see if there's something that we can do to help provide that education that might help the member to understand the potential benefits as well as the risks, to see if they're willing to take that medication. One example that we often run into is, say, for example, what we call a statin drug that's used oftentimes to lower cholesterol, but we also use that medication to lower heart risk, heart disease risk. And so, for example, in a patient with type 2 diabetes, even though that patient may not have high cholesterol, we know from the evidence, and these are drugs that have been around for 30, 40, 50 years, we know from experience that these drugs help prevent heart attack risk. And so they reduce someone's cardiovascular risk that may be at higher risk for developing problems. And so sometimes patients don't take a drug just because they're like, well, I don't have high cholesterol. Why do I need a cholesterol drug? And that's where our pharmacy teams can really come in and help educate about, the preventative measures that we want to take. And then ongoing, once the patient starts the medication, we look at those secondary reasons why a patient may be not adherent. Are they forgetting doses? Is it a cost issue? Are they having side effects? So really, again, working with our teams and our clinical pharmacists, even behind the scenes, we look at the alerts that we can get through our integrated health record, working closely with the provider to identify proactively when a patient may be becoming non-adherent to try and head that off, just so that we don't get into a situation where a patient goes off the medication completely if we think there's still benefit for that medication to be taken. And then working under our protocols, even in pharmacy, oftentimes we're able to make any medication adjustments as well. So if there's a problem with, maybe the dose recently got escalated and we need to go down to a lower dose for a period of time, we're able to do that with our pharmacists partnering with our physicians and the protocols that we have in place. And then again, also looking at medication adjustments on the side of, switching to a lower cost alternative if cost is a barrier, or looking at what options we may have with that. One of the things that really does help with the alerting is that we're often able to identify, as I mentioned, like patients who may be coming in to see a clinician. We actually have alerts set up on our integrated health record that will actually highlight for a provider prior to the visit that a patient may not be taking a medication as prescribed. And so it really does prompt our clinicians to have conversations at the point of care to really understand more. And then if needed, clinicians can refer that patient over to our pharmacy services to help with any issues that the patient may be experiencing to see if we can improve adherence on those meds. Next slide, please. So just again, with this integrated pharmacy care, we really try to meet members where there are. Most of our population here at KP is a working population. Most of our services are all done telephonically. So we do a lot of patient management over the phone. So that keeps patients, at their work site, at their home. And then we're constantly looking at what programs we can put in place to help manage our patients so that they get the best out of their medications once they go home, once they leave the provider's office. And one of the programs that we have in place is called our Outpatient Pharmacy Clinical Services Program, where again, that alerting that I mentioned in our integrated health record that our clinicians see, we also have alerting that can happen in our pharmacy dispensing system as well. So the two systems are connected together such that we have flags that can occur in our outpatient dispensing system so that our pharmacists and technicians at the point of sale of a prescription, whether it be in mail order or whether it be in our retail community pharmacies, are able to see if we have any gaps in care, if a patient is non-adherent with the medication, so that when they counsel the patient, they can dig into that a little bit more. And we've actually studied programs like this to see what benefits and outcomes we get as a result. And as you can see, we compared patients in the OPCS group to usual care and saw significant improvement in medication adherence by patients that are part of our OPCS program. And so this is something we continuously look at, how we can improve that. And then again, how can we continue to refine those alerts and even look further upstream? We're starting to get into the space of how do we look at predictors, or how do we look at a population of patients and try to identify where we think a patient may become non-adherent before they ever have actual non-adherence. And so that's using, machine learning, artificial intelligence, those types of things to look at our population to see where we can identify areas of risk, areas of places where we might want to intervene so that we can try to improve medication adherence. I think many of you probably know this is, measures that we see from Medicare. Medicare 5-star ratings are based a lot on some of our medication measures around adherence. We see it in HEDIS and other quality organizations. And so this is also something that we take very seriously in pharmacy as well, and really look at how we can support not only our members, but our healthcare teams across the continuum when we look at medication adherence. Next slide. So Jennifer mentioned a little bit at the very beginning about, talking about misuse and in particular with opioids. And this has been a huge problem, not just here at KP and in the Pacific Northwest, but across, the entire United States. I think we've all seen, and many of us have probably personal stories of where we've been impacted by medication misuse. And oftentimes we see it in the opioid category. And we have some pretty robust programs around how we look at not only opioid medications, but really any particular class of medications that have a high potential for misuse. This is something that we look at very closely. But for today's purposes, I'll primarily focus on some of the opioid products in particular. And this is really something that we started working on back in 2009. And so it's something that we've had a lot of experience with to really look at from, again, the point of prescribing all the way to how patients are taking these medications, where we can improve safety and quality for our members. And that's really what this is about. This is really about keeping members safe and really looking at where we have potential misuse occurring and what we can do to try and prevent these types of issues from even occurring. So we really look at how we can prescribe lower doses, for example, and get agreement from our clinicians about, say, for a certain surgery or certain condition. We know that a patient may only need a couple of days worth of pain medication. So how do we make sure that we're only prescribing a couple of days versus prescribing a standard 10-day supply, where the patient then has excess that has the potential to be misused or even taken by someone that it wasn't prescribed to. And so that's something that we look at. We look at how we can help lower doses, looking at alternatives to opioids wherever we can. That may include non-medication modalities. That's something that our teams are well versed in as well. And we have a team in pharmacy that's dedicated to just this topic, where they assist our clinicians, and clinicians can refer patients to pharmacy, where we can have an impact in reducing, again, risk in this particular patient population. And I would say the biggest area where we help here is in helping patients taper down. So really looking at how we can get them on the lowest effective dose that's going to control their pain. And we've had many success stories, I can tell you, of patients that were very reluctant to taper their dose. We've coached them through the process, and in many cases, we're able to completely get them off of these medications. And it's amazing how some patients come back to us and say, "Oh my gosh, you're a savior. Like, we feel so much better off these medications than we did on them." And so it's really been a huge impact that we've been able to make here in this space, and something that we continue to look at. One of the other pieces that's really important here, and especially giving, kind of the addiction pandemic, and, probably hearing a lot in the news about accidental drug overdoses, especially with kind of the synthetic fentanyl that's been out there, that doesn't come through regular pharmacy channels, but is through basically black market, comes on to patients get in their hands, and oftentimes it's a very potent drug that can cause overdoses. And one of the things we've been acutely looking at is how do we get more of what we call naloxone, which is basically an antidote to opioids that can be given in a situation that can help save a patient's life if they do overdose. And so we've got programs in place where we're looking at, for certain patient populations that are prescribed an opioid, also looking at how we co-prescribe naloxone at the same time to try and keep our patients educated and safe. And there's even been laws put into place now in Oregon where we're able to dispense naloxone to caregivers. So they don't have to be on an opioid, but just in case they want to have one on hand, if they have a family member, a relative, a friend who they know is using opioids or other drugs like that, we're able to dispense naloxone in those cases. One of the barriers to that has been cost. Naloxone is not an inexpensive drug. For us, it's still a member's copay, but if it's somebody using it for, wanting to use it for a friend or relative, they end up having to pay the full cost of the medication. Many of you may have heard the FDA has now approved naloxone for over-the-counter use. It's not on the market yet, but what we're hearing is that probably by summer, and it's not clear to me if it's going to be, early summer, midsummer, late summer, but sometime in that time frame, we should expect to see a product come that's going to be available over the counter. Don't know anything yet about what the cost of that medication will be, but that's something we're going to watch very closely as well and see how that may impact our patient population here and help curb kind of the potential that we see for drug overdoses through accidental overdose. Next slide. So just looking at some of the data that we've been able to show, since we've really been studying this closely, just looking at the last 2016 to 2020, so for that 5-year span, we were able to reduce our opioid prescription rate by 65%. And in particular, in the Northwest, we were a little bit higher than our KP average at 69%. And that's through many of the ways that I've already mentioned, through that integration that we have in our clinical pharmacy teams, working closely alongside our physicians and making sure that we're able to deliver that value and the quality that we want and really keep our patients safe whenever an opioid prescription is required. And so really proud to see, where we've come and then the journey that we're still on. We're constantly looking in this space to see where we can further innovate, where we can further reduce risk for our patients. And so, again, another example here is there's likely going to be some changes to Medicare quality measures that are coming, and they're starting to look at combinations of medications. So for example, a medication like an opioid, but a patient may also be on what we call a benzodiazepine for anxiety or other conditions where, using those two drugs together may increase someone's risk of having significant side effects. Or maybe they're on a drug to help them sleep and on an opioid. Sometimes the combination of all three. So we're really starting to look at those areas as well and look at where we can help keep our patients safe and reduce that risk overall, so that we can, again, get the most out of these medications when we're needed, but truly only use them where it's required, where we don't have safer alternatives that we can use. Next slide, please. So that's the end of what I had prepared for you all today. Would love to help answer any additional questions if we do have those. And then just before we get to the Q&A, I just want to turn it back over to Jennifer and she can do just a short wrap up. So Jennifer, back to you.
Thank you, Junior. Really, really interesting information. One of the things before we do the wrap up that I'm interested in is understanding you were talking about machine learning helping us to identify when a patient has not yet become stopped taking their medication appropriately, but we're seeing warning signs. Do you have like a real life example of what that looks like?
Yeah, so some of the examples where we're looking at is looking at like socioeconomic factors, like even looking at, for example, in certain patient populations, like Latino population or Black population, are there certain characteristics that we can look at and say, well, this population of patient, we already know from data, like there's health equity issues out there, right? But are there any factors that we can help identify early on? And so, in some examples, I guess just to be more specific, like really looking at, if the patient is prescribed a medication, they haven't picked it up in a certain amount of time, it seems likely they're not going to pick that up. So how do we intervene early in the process? But then also looking at, like I said, other things like comorbidities or other disease states that a patient may have. We're trying to understand if those factors may play a role in how a patient may be adherent or not adherent. We're just at the very beginning stages of this. I'd be remiss to say if I said we had it all figured out, we don't. But it's something that's exciting that I think is coming down the pipe, and something that we want to try and be ahead of the curve on. So again, we can really maximize our resources and make sure that we're intervening on the population and the group of patient that's going to get the most benefit from our services at the time that it's needed. And then we can flex our resources, appropriately to those populations where it's going to make the biggest impact. I hope that helps.
It definitely does. Thank you. So I don't see any more questions coming through, but I'll continue to monitor as we close up in case anyone has something else that they'd like to ask or get some additional detail on. In the meantime, just wanted to recap. Hopefully you got from it what we were talking about before, is how we continue to deliver personalized care, but we leverage that broader population health aspect and the size of the system and the integration to be able to maximize the effectiveness, the efficiency, and the quality of care. And then how we're always looking both back and forward to make sure that we continually improve and evolve the work that we do in our pharmacy program for our members, because we're seeing things change every day there, whether it's, the biosimilars that you're talking about, the new specialty medicines, $3.5 million a dose. That's pretty incredible, but at the same time has some very, very significant positive impacts for the members. So overall, just looking at what is that broad strategy and continuing to evolve. So thank you for helping us understand that. Oh, we do have a question that has come in. So it says, how does KP participate in drug trials and participate in developing new treatments for the future? So Junior, would that be for you?
Sure. Yeah, I can speak to it a little bit here. I would say the first thing, especially here at Kaiser Permanente in the Northwest, we actually have a separate research department and a separate research team. We often collaborate with them on the pharmacy side, but there is a team of clinicians, and they actually have, I know of at least one pharmacist on their team that actually will help participate in clinical trials that are being done across the country. So say, for example, a clinical trial is looking, and I'm just making this number up, but say they're looking to enroll 100,000 patients and they want a diverse population across different geographic areas, sometimes not even, just in the United States, but around the world. We will often petition or apply to be a site or a center for some of those research trials. So at any given point, we have several different clinical trials that we are a part of. I would say not only are we involved in that aspect of it, but this is where we come in as far as the new treatments for the future, is oftentimes we're devising our own clinical trials or our own research that we want to do to help answer a particular clinical question that we may not think is, that there's not good literature or good evidence out there on. And so we partner with that team very closely. And in particular, in pharmacy, as an example, I actually have, we have a clinical pharmacist on our staff within pharmacy that's in our oncology department, because a lot of the clinical trials that we do are participating on oncology drugs that we're constantly finding, new drugs and new indications for which we can try to treat cancer with. And so we have a person just dedicated to helping running the medication portion of some of those trials within our oncology department, again, partnering closely with our physicians. And then just the last thing I'll mention, and this is a small piece, but it's one near and dear to me, is we actually are involved in pharmacy and training the next generation of pharmacists. And we have residency programs that we do, and all of our residents undertake a year-long project, a research project. And we really try to promote a project that, again, is going to be beneficial to KP, to our members, but to the scientific body of literature that's out there. And we really encourage them to try and get those research studies published. And so many different ways that we're involved in some of the research.
Excellent. Thank you so much. A couple of other questions that have come through. One of them is about will any training be provided at the group level for how to administer Narcan? And I think that's the employer group level. What I understand is that we do one-on-one training for our patients, and caregivers haven't expanded past that at this point, but is definitely something we can take back internally if there is a desire and need for that. And it sounds like as things progress through the summer, maybe a little more available for people. I think you mentioned that it'll be over the counter as well. So Interesting thought. I don't know if you have anything else to add there, but something we can take back to the organization.
Yeah, I agree taking it back. And I think, one thing to remember here is that, in order to come to market as an over-the-counter, it will have to have clear instructions and be able to be easy to use for the general public. Because again, we may have patients who are purchasing that product now without ever talking to a pharmacist or anybody, right? They'll just be able to go in their local pharmacy, purchase it, and exit just like they do anything else. And so I would, again, I'm kind of venturing to guess here that whatever product comes will be pretty simple to use and to administer. The products that are out there now, for the most part, are also that way. There may be some nuances with the device, but I think when we see what happens with the OTC, it would be worth reevaluating to see if there's still a need for that.
Yeah, excellent. Thank you. And can't forget the complexity that surrounds the need for the use of it, right? So having that support through the system, if you're having to administer it, what that looks like. Another question that you had briefly mentioned rebates and how we work to achieve the best price in the beginning, but wanted to a question came through, says, can you speak to KB's position on prescription drug rebates? So maybe dig down a little further there about our approach and the reasons for it.
Yeah, so as I mentioned, we try to steer clear of, negotiating contracts that have rebates on the back end. So a lot of times those rebates are structured based on how much of a certain drug you're going to use and the price that is quoted or that you pay up front. And a lot of times when that happens is the member's price is based on that price up front. It doesn't reflect in what may come on the back end as a rebate. And so for those reasons, we try to avoid, we think there's greater transparency in us negotiating with the manufacturer to get that upfront discount. And then once we negotiate that discount price, that's how then we reflect what our member price may be. Say, for example, a particular member doesn't have a prescription drug benefit, which is very few of our members. But if for any reason they had to pay the cash price, they would be paying the cash price based on that discounted price that we negotiated up front. We pass those savings on to our member. Whereas in a rebate model, that may not be the case. There's a lack of transparency there, and the price that's quoted to the member may still be the upfront higher cost, and the member may never know where that rebate goes on the back end. And that's what we try to avoid. And so our position, like I said, is, we try to negotiate those upfront discounts rather than a rebated contract on the end. And we really don't do the traditional PBM model, pharmacy benefit manager model, that you may see with other insurers where they negotiate a lot of those rebated contracts. Because again, as a middleman, that's where they can make some of their money in revenues. And so we avoid that. And our relationship with most of our PBMs is strictly transactional, meaning that we just use them to help process our claim to make sure that the member gets charged the right copay. But we do all of our own contracting for the most part on those drugs. Does that help answer that? Or is there anything I can further?
I think it does. And I think to your point, it's one thing for if a member doesn't have it, but also if they have co-insurance versus a copay. So
Right.
the cost of the initial upfront drug, I would also guess that administration is reduced at that point if you're doing, rather than connecting it to each prescription.
For sure.
Well, I'm mindful of the time, so if there's any other questions that come through, we will make sure that we follow up with the attendee who asked it. And I wanted just to take this opportunity to thank you both for your time, your preparation, and all of the knowledge that you've shared today, and to thank our audience for their time, their attention, and their interest in this very important topic as we all work together to really improve our healthcare system, the affordability, the quality, and the health of our communities. So thank you again, and we look forward to seeing you next time at our next speaker series.
Thanks, Jennifer.